Thank you for joining us, Dr. Kevin Tang. My name is Khalid. I'm one of the editorial fellows working for the Journal of Immunotherapy and Precision Oncology. Today we're going to be talking with Dr. Tang about his review article published in JIPO titled Real-World Experiences of CAR T-Cell Therapy in Large B-Cell Lymphoma and How Similar Are They to the Prospective Studies. Thank you for joining us, Kevin. How are you doing today?
Doing pretty good. Thank you for having me.
Great. So a few questions about this publication. To start off with, what prompted you to carry out this study?
I think the concept behind CAR T-cell therapy is fascinating and ingenious. Oncologists have been trying for a long time to harness the anti-tumor effects of the immune system. For example, in terms of leukemia, we've been trying to use the graft versus leukemia effect for patients that are at higher risk for relapse. Now we have a treatment option for lymphoma where we can do something similar and modify a patient's own immune system to target specific malignant cells. The pivotal trials from the clinical trials for the current commercial CAR T-cell therapy products for large B-cell lymphomas have impressive overall response, as well as survival rates for patients that historically have had bad outcomes and limited treatment options. The reason why we conducted this study was because we wanted to figure out whether or not the real-life practice experiences held similar outcomes to those in clinical trials, and luckily they do.
Great. And were you expecting that the real-world experience to be similar to the clinical trials that resulted in FDA approval when you started looking into this data?
I was really hoping so because of the high response rates from these clinical trials. For example, in ZUMA-1 for axi-cell, at 2-year follow-up, the overall response rate was about 83%, and the complete response rate was about 58%. Clinical trials rightfully are designed to select for specific patient groups, patients that are at lower risk for complications from treatments. But as many of us know, many of our patients in clinical practice have significant comorbidities that put them at a higher risk, such as patients with renal, liver, or cardiac dysfunction, or even poor performance status. Luckily, despite the differences in the comorbidities and the severity of the comorbidities that we see in real life practices, these patients in real life do almost as well as the patients in the clinical trials.
Great. And I'd say the question that I ask is, what is the most important message kind of from your review article that you'd like to leave with our readers?
I think that the most important thing would be that if you're worried that your patient with relapsed aggressive B-cell lymphoma isn't that healthy 50-year-old with no past medical history that we see in clinical trials, or may have some sort of moderate, chronic, or cardiac dysfunction, or even CNS involvement, these patients can still be referred to CAR T-cell treatment centers and may still be candidates for treatment.
Great, that's great to hear. And you briefly commented on this, but what would you recommend, to make sure clinical trials are more representative of real-world populations and give us data that's more applicable to real-world populations?
Yeah, I think that we'd like to see more patients that are more representative of the real world. So it would be important to include patients that we see commonly in clinics, such as patients with significant comorbidities, such as CKD stage 3, but also patients that are at higher risk for developing large B-cell lymphomas, for example, patients with HIV. Patients with HIV were initially excluded in these clinical trials, but we know from several smaller case studies that patients with HIV also tend to do pretty well with CAR T-cell therapy.
Great. I guess the final question that we have is, what are the next steps in studying CAR T-cell therapy for patients with large B-cell lymphoma, in your opinion?
I think it would be interesting to see if CAR T-cell therapy can play an earlier role in the treatment of large B-cell lymphoma. Currently, CAR T-cell therapy is approved as third-line treatment in this setting. However, there are several clinical trials ongoing to see if we can use it earlier, perhaps as an alternative for first relapse setting, as an alternative to platinum-based salvage therapy followed by consolidated autologous transplant, namely ZUMA-7 for axi-cell and Transform for lyso-cell. I'm excited to see the outcomes for these studies.
Great. Well, thank you so much for those wonderful responses. Is there anything else you'd like to inform us or tell us about your study, or anything else you'd like to leave us with?
I think that I'm just very excited to see what else is out there for CAR T-cell therapy with newer products coming out for other disease processes, such as the BCMA1 for multiple myeloma. So I'm just very excited to be part of this evolving field.
Great, great. Well, thank you so much, first of all, for doing this review article. It was great to see. As always, we always hope that the good results that we see in trials translate into good results we see in clinical practice. So it's really useful to know that that's actually happening, and then in particular to study the populations that are kind of excluded from those trials. It's very useful to have that information and help guide oncologists and clinicians make decisions in these patient populations. Thank you for doing that, for looking at that, for submitting it to our journal, and thank you for taking the time to meet with us today and answer our questions about your study. We really appreciate it.
Thank you very much.